right, great. So this is a nice big group, so I'm going to try to be loud. If you can't hear me, let me know. What we're going to talk about today are drugs of abuse, and this is actually a kind of, I think, a sad and depressing topic. So I'm going to try to make it a little light, and I put some dramatic photos in there for effect today. So even though it is a pretty serious and sad issue, we're going to try to make it a little bit light today. What we're going to do, I'm going to talk about the drugs of abuse section for about 15-20 minutes, and then Chad is going to talk to you about behavioral health resources for substance abuse in this area. And then I'm going to jump back in and talk a little bit about MAT, which is medication-assisted treatment, is buprenorphine for opioid dependence. So we're going to kind of go through that, and then you all have your breakout groups and talk about some specific real cases. But before we start, I have a little bit of a pre-test, so I'm trying something a little different here. This is totally for your own benefit. No one's going to look at it, no one's going to grade it, but just to get you start thinking as we go through the presentation. So let's take a second and do that first. Okay, so the first question, if you look at the front page of the handout, number 1, name 5 health risks associated with chronic heavy alcohol use. So just take a second and see if you can think of 5 of them. There are more than 5, but see if you can come up with 5. I'll give you a second for that. All right, see everyone writing? And this is going to be important because these are things that you all see every day when you're out working with patients. All right. The next ones are basically yes or no. So number 2, if a woman regularly has 1.5 glasses of wine per night, is that considered to be high risk drinking? And that's just a yes or no. So you got a 50-50 chance. And then the next question, number 3, along the same lines, if a man regularly has 2 beers a night and then he has a 6-pack over the weekend, is that considered high risk drinking? Yes or no? And again, I'm not saying alcohol abuse. That's important to note. It's high risk drinking. All right. Moving down, number 4, what is meth mouth? So just a quick idea, what is that? For those of you who watched Breaking Bad, you probably have a head start. And then the last question, how is buprenorphine, which one of the brand names is called Suboxone, how is that different from other opioid medications? So like your oxycodone or fentanyl or morphine, how is this medication different? And if you haven't heard about it, don't worry, we're going to talk about it. All right, so we'll be talking through a lot of this as we go. Let's start with alcohol. Okay, and you can look at your little quiz as we go through. Hi. So why am I starting with alcohol? I think alcohol doesn't always get the media press that it used to get. But if you look at the numbers, alcohol is still one of the most serious drugs of abuse that we have. And it's legal, and it's culturally acceptable in most cultures. So it's actually pretty tricky because where the other ones are illegal, it sometimes is more clear that they're a problem. But alcohol is a little fuzzy, and a lot of people forget about it. So what are some of the chronic health risks of alcohol use? And again, this isn't necessarily alcoholism, but just high-risk drinking what is considered to be high risk, and we'll talk about that in a second. So what are some of the things that you might see in your patients who have chronic heavy alcohol use? You might see anemia. Alcohol affects anemia. Cancers are highly associated with heavy alcohol use, and people tend to forget about that, but alcohol is actually a significant risk factor for a number of cancers, but specifically mouth, throat, larynx, esophagus, liver, breast, and colorectal. So if you're working with patients who have cancer, who have other risk factors for cancer, thinking about how much alcohol they're drinking may actually be really important. Again, not necessarily an alcoholic, quote unquote, but heavy alcohol drinking. Cardiovascular disease, sometimes we forget about that, but heavy alcohol use can lead to elevated triglycerides, hypertension, stroke, cardiomyopathy, and atrial and ventricular fibrillation. So again, if you're seeing a patient out there and they already have been in the hospital for some cardiovascular problems, thinking about how much they're drinking may be really important. Cirrhosis, this is the one we all think of, right, with heavy alcohol use that destroys your liver and you get a cirrhotic liver. Dementia. Heavy alcohol use can cause a very specific type of dementia. And sometimes you'll see this when you're out working with people and they have this dementia which doesn't really look like Alzheimer's and has a lot of behavioral disinhibition. So you might see people who are kind of hypersexual or really having very, very poor judgment. I know that comes up a lot in the cases we talk about people with poor judgment. Think about it, if they're drinking a lot over many, many years, maybe even they're not drinking now, but maybe they have like a 40-year history of drinking, you know, that has a big impact on their brain. So that's something to consider. Korsakoff syndrome is a specific type of dementia related to alcohol. Depression. Alcohol is actually a depressant, even though sometimes with the first few drinks people get a little bit more of a euphoria, but then it typically becomes a depressant. Seizures. Alcohol, we've talked about a lot how withdrawal from alcohol can lead to seizures as well. And when people get in the hospital and they don't know that they're a drinker and then that person is not drinking, they can be at a risk for having withdrawal in the hospital. That happens a lot. Gout. Gout's kind of an oldie but a goodie. That's been around a long time. Alcohol can make that a lot worse. This is one I think is particularly relevant for you all, increase in infectious diseases. So people who drink heavily are at a higher risk of getting sick from an infectious disease. So if you have a patient in care management that's fragile and they're drinking a lot, that's going to increase the chance they're going to pick up infections and they're going to have a much harder time fighting that infection off. There's a much better chance that an infection is going to lead to a hospitalization for those patients. Nerve damage, numbness, tingling, pain, muscle weakness, loss of bladder, bowel control, impotence, diarrhea, nausea, vomiting, constipation. Sometimes we forget about that one too, but alcohol has a big effect on the nerves, especially the nerves of our gut. And pancreatitis, that's one you probably have all seen at some point where you get an acute inflammation of your pancreas, which can be quite serious. Okay, so hopefully when you did your little quiz you got a few of those, but maybe there's some that you don't think about as much. Okay, so now this is the one that may surprise some people. It surprised me a little bit, I have to be honest. What does SAMHSA consider high-risk drinking? So high-risk drinking is for women more than 3 drinks on any single day, or 8 or more drinks a week. So for that question you had about the woman drinking a glass and a half of wine every day, is she a high-risk drinker? According to that standard, she is. That's a little surprising, right? I mean, I think a lot of people who drink a glass and a half of wine a day would not consider themselves a high-risk drinker. But when you say high risk, again, think about it in a medical sense. It's higher risk of having chronic medical problems related to the alcohol use. Not necessarily being an alcoholic or having behavioral problems, but you're putting yourself at a higher risk for those medical issues. What about men? More than 5 drinks on any single day. Okay, that kind of makes sense. 15 or more drinks a week. So what about that man who's drinking 2 beers and then a 6-pack on the weekend? Is he a high-risk drinker? He is, by these standards, right? And I think we all, you know, socially, that would not be probably thought of as high-risk activity for a big guy to drink 2 beers a night and have a 6-pack over the course of a whole weekend. That would, socially, in most cultural situations, probably not be considered high risk. But medically, it is.
Can I just made a comment to Julia, cut back to 1 glass of wine a day, and then you're not considered.
Then you're not considered high risk.
It's hard to imagine a half of a glass of wine makes that much difference.
But if you think about it every single day, day in, day out, what's it doing to your liver and what's it doing to you? It can. So these are somewhat, arbitrary guidelines. But I think the point is that we tend to think about, acceptable drinking and alcoholism, and we forget that there's this whole spectrum of drinking that may be causing physical problems, even though it's not causing behavioral problems. And for you all in your work, this is really important. Because if you're trying to keep people healthy and keep them out of the hospital, right, drinking may be a big topic that you want to talk about with them. And it's not all or nothing, right? I mean, if you have someone, you can say, you're a high-risk drinker. Can we pull you back and drink less so that you're not a high-risk drinker? Not necessarily that you can't drink at all. So I think it's really important when you're thinking about care management. Okay. I don't know a better way to scroll down here. Now, for those of us who are very vain, I'll include myself in that group. What does alcohol use do to your face? And as a care manager, when you walk into someone's house, what do you see? The first thing you see is their face. You may not be doing a physical exam on them, right? Okay, so chronic alcohol use, how does it change your facial appearance? This is kind of a fun program online on a website that you can take your own picture and then put it in here, and it shows you what you would look like with heavy alcohol use. So this young gentleman here put his picture in, and it showed what he looks like before and after a number of years of heavy drinking. So what do you have? You have broken capillaries. So that's typically, on people's nose and their cheek where you see those little fine broken red capillaries. That's a sign. Bloating in the face, or just like a very red complexion. Those are all clues maybe that person may be a drinker. So when you walk in the door and you see someone, or you go to the practice and you see someone and they have that kind of face, that might just start triggering a thought for you that, hey, maybe this is something I should ask about. So for this guy who did his picture, and I put the website in case anyone wants to play with it, because I think it's kind of fun. So they show him at 2 years drinking up to 20 years and kind of what he would look like. So I don't know, for some of the patients you see, whether you think their vanity would be strong enough to tell them, if you keep drinking, you're going to mess up your face. If you think their vanity is strong enough, that may be part of that motivational interviewing that we talk about, a way to get through to them. Okay. Any question about alcohol? It's there, it's out there. You're seeing it every day. It's just whether you're asking or not. But I guarantee you it's out there every day in what you do. All right, let's go down and talk about opioids. So I put opioids second. I'm not going to go through all the drugs of abuse. I thought I'd just hit 3 that have particularly high health risks. So opioids are getting a lot more attention, right? It's just building and building and building in terms of the epidemic. They're saying they don't think the bubble has totally burst yet, that we still have more and more coming. So you hear a lot about it. We talk about it a lot here. A lot of the patients you see are on some sort of opiate, right? Either oxycodone, hydrocodone, fentanyl, morphine, and then methadone we talked about a little last time. But a lot of people are on opioids, and this is a big, big issue right now. Why are opioids, again, not thinking about abuse and addiction, but why are they a health risk? So what are some of the biggest health risks of opioids? Constipation. This is actually a pretty big one. If you have someone on opioids, you should pretty much always ask them if they're having constipation. Because if you ask, pretty much everyone will tell you they have some amount of constipation. Whether it's just a little bit and doesn't bother them, or whether they're taking over-the-counter stuff to counteract that. Sometimes if you ask, you're going to find out they're taking a lot of over-the-counter stuff. Or whether they're actually getting blockage because they're so constipated. This is a big issue, and this is pretty much almost everyone who's on these meds routinely can have this problem. Sleep disordered breathing. So a lot of the cases we talk about in this group have to do with people with respiratory problems, right? COPD, emphysema. They're at higher risk of having sleep disordered breathing. And then you throw some opioids on top of that, and things can get a little dangerous. If your respiratory rate gets low enough and your oxygen is low enough, things can get actually pretty dangerous. Fractures. This is a really, I don't know, I hadn't thought about this one too much when I was preparing this, but people who take chronic opioids are at very high risk for getting fractures. And they're not sure, exactly how that all works, but it seems like the bones become more fragile in general on chronic opioids, similar maybe to chronic prednisone. So fractures is a big one. So if you have a patient on opioids who's getting fractures routinely, that might be something to think about. This is another one I don't think we think about so much, the hypothalamic pituitary adrenal dysfunction. So the one in particular is this decrease in, again, thinking back to your classes, I was trying to think back to med school days, decrease in gonadotropin releasing hormone that could cause hypogonadism. So for men especially who are younger, who are on chronic opioids, they can have a lot of sexual dysfunction and infertility due to the opioid use. So again, like sometimes when you're trying to do motivational interviewing with someone, a young guy who's on a lot of opiates, this might be an in for them if they're having trouble with this. Your testosterone levels tend to go down. Overdose. This is one we talk about all the time. Respiratory depression, bradycardia, hypotension can lead to overdose. Intestinal blockages. Again, if the constipation and the nerve damage gets so bad, you can actually get totally blocked up, which is a medical emergency. Sedation, dizziness, cardiovascular events. This is one sometimes we don't think about. An MI is actually more common when you're taking opioids. Immunosuppression. Again, we talked about this with alcohol. These patients are more prone to get infectious diseases. So that's something for you all really important. If you can help them get back on their opiates, you might help them stay healthier and not get as many infections. And then addiction and misuse, which you see in people, if they've had no history of any addiction problems their whole life, they might be 50, 60 years old, get on these meds and have problems. You don't have to have had a history of substance abuse to get hooked on opioids. So that's something we always think about. Okay, another thing that you might see when you go out to see patients is withdrawal from opioids. If the doctor has suddenly cut back on their dose or they tried to quit taking them, what does opioid withdrawal look like? This is a little hard to read up here. I don't know if you can see it. I'm happy to send it out to you all if you want to see it. There's a withdrawal scale called the CALS. If you want to be formal about how you assess withdrawal, you can use the CALS. That's the one that we normally use. But just kind of more informally, what do you see if somebody's in withdrawal? They're typically sweaty. They have a rapid pulse. They're kind of restless. They can have pupil dilation, bone or joint aches. This is one they talk about a lot. Runny nose or tearing, upset stomach, tremor, yawning, anxiety, irritability, and goose flesh skin, or so when you go see someone and they have a couple of these, especially if you see a lot of runny nose, tearing, a lot of sweating, and dilated pupils, those are signs that you may observe that can clue you into someone in withdrawal. And there could be a lot of reasons they're in withdrawal. Again, if their doctor cut back the dose, or maybe they were in the hospital and they were on a lot of opioids and now they're discharged and they're not any longer. But this is a really, really uncomfortable, horrible feeling. It's not lethal the way alcohol withdrawal could be, but it's pretty awful. And if you see people who are in bad opioid withdrawal, they're really miserable. So even a little bit of opioid withdrawal could make you really irritable. So again, that's something to think about when you're seeing people. Okay, I'm going to skip over the part about MAT. I'm going to get to that after Chad talks a little bit more. And then the other drug of abuse I put in here was methamphetamine. I think, this one again is not quite in the media the way it used to be. I think in some parts of the country there's more meth than here in North Carolina, where we're still seeing a lot of opioids and alcohol, but it's certainly out there, and I'm sure there's some people that you all have seen that have had meth issues. Meth is really, really bad for your body. So it's got a lot of health risks. You have addiction. You actually have changes in your brain structure and function if you're on meth that can lead to deficits in thinking and motor skills. You can actually have motor deficits from long-term meth use. You can have increased distractibility, memory loss, mood disturbances, violent behavior, psychotic features, weight loss, severe tooth decay and tooth loss. This is that meth mouth we are going to see in a second. And skin sores, we're going to see that too. So a lot of cognitive problems with meth. So not just the addictive behaviors that are problems, but a lot of real serious kind of cognitive executive function problems. And again, if you're seeing someone that has judgment, you think has poor judgment, maybe they're not using meth now, maybe they used it for 15 years before. These are things to always think about. So those are kind of some long-term effects of meth. And then for the shorter-term effects, and this is what you'd see on TV, you know, when they're portraying people on meth. You have more of a stimulant property, right? You have increased attention, decreased fatigue, increased activity and wakefulness, decreased appetite, a euphoria or rush, increased respiration, rapid or irregular heartbeat, and hyperthermia. So it's kind of, if you think of it more like a stimulant, the acute use of meth is more of a stimulant, where the acute use of an opioid is more of a depressant. They both can have euphoria. Okay? So this has been, I feel like, again, kind of on TV and the media, you've seen a lot of portrayals of short-term meth use. Okay, so here's where we're going to get dramatic. Kelly, were you the one who found these first?
Yes.
Yeah. Again, it's not a funny issue, but I do think that this is a pretty dramatic portrayal of what can happen to people, and these are real pictures. I think this website took mug shots of people, like over time as they would get multiple arrests and come through, they'd take their mug shot, and you could really see this progression. Now this guy is probably one of the more dramatic ones, but there's some other ones as well that are still pretty awful. What happens to your skin? Again, for the vain people, the vain young people out there, this potentially could be a motivator to stop using. You tend to get worse acne, you get skin picking, so anything that you have that you're picking at is going to get worse, and you're going to get sores that don't heal. You actually lose musculature and fat in your face, and so you get this really weird, like, drooping of the skin on your face. So if you've ever seen anyone like that, it's pretty dramatic, and it's got this kind of zombie, for lack of a better word, you know, look to it. It's very pronounced if there are people like this who are serious users. And then here's that question about meth mouth. So what is meth mouth? There are a couple of things that happen. Your tooth enamel will get dissolved. The blood vessels in your mouth will shrink. So the blood, you know, can't get really into your mouth and to your teeth. So the rate of decay is very, very rapid. And then you have less saliva being produced. So you just kind of have this very rapid escalation in tooth decay. And this can happen pretty fast. Also, they mention, of course, if somebody's using a lot and they're high a lot, they're probably not, like, you know, brushing and flossing their teeth. So it all kind of piles together to get this very dramatic change in dentition with meth. So this guy they showed at age 23, and then 25, and then another point 25. I mean, that's for 2 years of use. I mean, that is really dramatic, and it's pretty awful. And I don't think you're going to see someone quite that dramatic, probably. But there's some other pictures down here a little lower where it's a little less dramatic. So like this guy is 37 to 39, so this is 2 years difference. The woman next to him goes from 27 to 30, so this is a little more subtle, right? I mean, this is more what you might be seeing. And then down on the end, 23 to 28. And you can see the skin sores. You can see a little bit of change in the musculature and the fat in their face. And the teeth, these people aren't really showing their teeth, but the teeth can get really dramatic really fast. So that's a little bit of a dramatic, if you want to look at the website, I put it down there. All right. Any thoughts on opioids or meth before I turn it over to Chad? No? All right. Smoking, we didn't do smoking this time because we did smoking last time. So in the interest, oh, you can smoke meth. Yeah, yeah, yeah. So I mean, smoking is definitely another substance, but since we did that last time, I didn't put it on here. Okay, so I'll turn it over to Chad. Methadone is really hard for people in those situations, but if you have someone who's just completely unemployed, who has transportation, you know, who needs that structure of a methadone center because you are there every day, sometimes it's a good choice. I'm going to spend more time just talking on buprenorphine because people don't typically know as much about that. So buprenorphine is the actual drug name. There are multiple brand names now. It used to be that Suboxone was the only one you heard about and they had a monopoly, but now there's a whole bevy of them coming to market. So Zubsolv, Bunavail, there's a generic form now of Suboxone, which is a tablet, and then there's like 3 more that are all coming out this year. There's also a long-acting form that can be implanted under the skin. That's not very popular, but they're trying to get it out more. So in the next year or 2, you might read more about that. So what is buprenorphine? Buprenorphine is different from other opioids, and this was your question at the beginning, because it is a partial opioid agonist. So if you remember your chemistry, you have receptors right on your neurons, and a chemical has to go and bind onto that receptor to activate the receptor. So an agonist is a chemical that floats around, jumps on the receptor, and activates it fully. A partial agonist is a little different. It floats around, jumps on the receptor, but it only partially activates it. So it has a different activation than a full agonist. So if oxycodone is a full agonist, buprenorphine binds to the same place but as a partial agonist. So what does this mean? Why does that matter? It tends to have less euphoria, less physical dependence, although you are dependent on buprenorphine, so don't make any mistake about that. If you're on buprenorphine, you are physically dependent on it. Lower potential for misuse. That tends to be because, again, the lower euphoria level tends to make it less of a drug of choice. Although people who are hooked on opiates on the street might take Suboxone, kind of like if they can't get anything else, they might still take it. So it does have a street value. It has a ceiling effect, which is really, I think, one of the nicest things about it as a prescriber. It's very difficult to overdose with buprenorphine because once it binds on, there's a ceiling. It's not like other opioids where you take more and more and more and you go higher risk towards overdose. Buprenorphine goes up and then there's a ceiling. So in terms of its safety profile, it's much, much safer. And it's much safer than methadone in that way, because if you took a whole bottle of methadone, you're really high risk to overdose. But if you took a whole box of Suboxone, you're still not at that high of a risk. So the documented overdoses on buprenorphine tend to be in people that have combined buprenorphine with benzodiazepines or other drugs. That's when you tend to see overdose. But just buprenorphine alone typically is very low risk for overdose. It has a relatively mild withdrawal profile. Again, you are dependent on it. There's no doubt about that. You do have withdrawal if you just stop taking it, but it tends to be an easier to manage withdrawal than some of the other opioids. Although I've had plenty of patients say how awful it is, and so it's nothing to be taken lightly. Why does buprenorphine help someone with opioid dependence? It suppresses the symptoms of withdrawal. So number one, you don't have that withdrawal. You take Suboxone, it's like taking your opioid. You feel physically normal, quote unquote. You have less cravings typically for opioids. This is really important for a lot of patients whose lives have been kind of hijacked by the need to get opioids. Just having reduced psychological craving is really helpful. It tends to reduce illicit opioid use because if you are taking buprenorphine, even though it's a partial agonist, it's actually very sticky. It has a high affinity, so it's very sticky on that receptor. So if you've taken your buprenorphine in the morning and then you go out and take some hydrocodone, the hydrocodone is not going to do anything. It's not going to get on that receptor because the buprenorphine is bound so tightly to the receptor that you're just wasting your money. And you'll hear patients say that. They'll say, well, I took my Suboxone and then I had a craving, so I went out and took some hydrocodone, but you know what, it didn't do anything. And I say to them, well, good. It's not supposed to do anything. It's because the buprenorphine was doing its job. So once people waste their money on that once or twice, they won't do it again. It blocks the effects of other opioids. So just what I was saying, it binds very tightly, and so even if you use stuff on top of it, it's not going to have an effect. If you're in an MAT program, what should you look for? So there's all sorts of programs out there. Some of them are more ethically run than others. Some of them are higher quality than others. What should you look for in an MAT program for buprenorphine? They should be having regular, frequent office visits for monitoring. That can run anywhere from once a week to once a month, typically. If you see a program that they're only coming in once every 3 months, that should be a flag that it's maybe not so great. They should have some sort of assessment and or treatment of comorbid psychiatric disorders. So they should have at least had an assessment. Even if the people don't treat the psychiatric conditions, there should be a process for assessing and referring those problems out. Because typically one of the biggest barriers to getting off buprenorphine is that you haven't treated your comorbid psychiatric problems. So to be a successful graduate off of buprenorphine, you really have to deal with those things. They should have some sort of in-office or referral system to psychotherapy. Now that's not saying all the patients are going to do it. I think the new Medicaid guidelines around buprenorphine have a pretty strong statement about people needing to be in psychotherapy, but kind of the reality of being out there with folks is that you can tell them to go and refer them 1,000,000 times, but sometimes they don't go, and then you have to decide what to do. Regular urine toxicology should be a part of any MAT program. So that can be an in-office quick read cup, or it can be a send-off to the lab quantitative test, or it can be both. I typically do both because the false positive, false negative rate on the cups is like 30%. So when you're making clinical decisions based on that test result, I don't like having that high of an error rate. But some people will do it in office only, and that's considered just fine. But it should be regular. They should have a regular check of the North Carolina Controlled Substance Database. So all doctors should be able to access this. If the doctor has a PA working with them or nurse, they can delegate authority to the nurse to look it up for them, but they should be checking it. If you're prescribing this medication, you should be checking that regularly, because the person might be getting all sorts of things from all over the place. Another good part of the program is to have an empty wrapper count. So if you've ever seen, has anyone ever seen a Suboxone film? Yeah, it's like in a little wrapper, and you have to get the wrapper open, which is actually pretty hard because it's safety proofed for kids. And then inside the wrapper is a little film, little rectangular film, which looks kind of like those Listerine breath strips they used to have. And the film goes under your tongue to dissolve. So when you're done taking it, you have this empty wrapper. So a good MAT program will have you bring the wrappers back, and then they count them. And you should be able to count out, you know, about as many as you had been given at the last appointment. Now I'll tell you just a quick side note on this. Just because they bring the empty wrappers back doesn't mean they're not selling it. I had someone who I would never have guessed in a million years apparently was quite carefully cutting each of the wrappers, taking the film, putting them in individual Ziploc bags, bringing the wrappers back, always had an exact wrapper count, and then was selling all the medication. And I got a call from the state police telling me that she had sold them my prescription. So you never know. You really need to have a structured program to try to avoid that, but even with the best case scenario, sometimes you can't. If you're an MAT provider, what does that mean? Chad said there's so few of them. Why are there so few of them? Other than the fact that many doctors are still very uncomfortable with this whole idea, there's some logistical reasons why there's not that many providers. If you want to be a provider, you have to complete a course, an 8-hour course on prescription of this medication. They do have online courses, so it's not like it's that difficult, honestly, but you do have to take an 8-hour course, and then you have to take a test, and then you have to apply to the government for something called an X number. So it's basically a waiver which gives you permission to prescribe this medication, and you get a special DEA number called an X number. So if you've ever heard patients or doctors talk about an X number, that's what an X number is. It says that you have the ability to prescribe this medication. Currently, the law says that in the first year that you're a prescriber, you can only treat 30 patients. In the second and further year, currently the law says you can only treat 100. So if there's a handful of providers in this area, maybe 5, I mean, that's a maximum of 500 patients that can be treated legally. So it's not a lot. Now there's a bill right now that they're proposing to extend that number to 200, which would help. But again, these are kind of major logistical barriers. One of the reasons a lot of providers don't want to do this, other than the fact that they're uncomfortable, is if you are a buprenorphine prescriber, you're going to get audited by the DEA. They're going to show up at your door out of the blue and say, give me your records. And if you don't have those records, they are going to sit in your office for a week until you provide them. And you're under a much higher level of scrutiny. And I don't know if this will change as this treatment becomes more desired by the government and by, the medical board. I don't know if that will change. But you're kind of under a lot of scrutiny. And I can tell you, after I've had 3 audits now, it's not really a very fun process to go through. I mean, luckily we have our records all in order to give them, but it makes you pretty uncomfortable as a provider. So that's another reason why providers are reluctant to get involved. Any questions about that program? I could go into all sorts of detail, but I don't want to take all of our time.
Tell me about the balance between those that are on buprenorphine. Is the goal to get them off the opioids, or is it a harm reduction sort of a thing that they're going to be on them?
This is a great question, and a patient just came and asked me the exact same question. And some doctors, I think, tend to be opinionated one way or the other, like you got to get off this as fast as you can, or you should just stay on this. But the way I explain it to patients is, this is something, it's at the beginning a risk management, right? At the beginning, the benefits of being on this medication clearly outweigh the risks, because you're doing all these harmful behaviors. You've had substance abuse, you're not working, you have legal problems, you're out of money, it's not helping your health. So in the short term, it's certainly risk management. Now, I think I alluded to this a little bit before. You got to put in the work. If you want to get off Suboxone, you have to put in the work. You have to find some sort of support, whether that's, I tell people, it doesn't have to be AA, NA. I mean, probably not going to work. So that, I don't know if that answers your question. I think there's arguments to be made for both sides. I will say that people who've done rapid detoxes off of Suboxone typically relapse in my experience.
I don't know, with all these new buprenorphine meds coming out, I know when we did Suboxone before, you can't just jump from taking a whole bunch of opiates straight to taking your Suboxone. So
that's a great point.
Yeah, there's a time frame there. You have to step down and stay off.
Right, so it's a pretty short time frame.
Yeah.
But basically, you have to have the opioid in your system washed out, and you have to be in mild withdrawal at least before you take your first buprenorphine. So if you're taking a short-acting opiate, that may be 12 hours, 24 hours. If you're on fentanyl, that may be a couple days at least. So it's really more like the goal is that you are uncomfortable, you are in withdrawal, you already feel kind of bad by the time you take your first one. So for most people, that ends up being like 24 to 48 hours for short-acting stuff. Most people on the street are using the short-acting because they get a little rush from it. Why is it so important? What would happen? Like, let's say you still had you had oxycodone on board, and then you took your first buprenorphine. What would happen? So remember that receptor, right? So say you took oxycodone, it's sticking onto the receptor. But now all of a sudden you put buprenorphine in, it's much tighter affinity. It's going to jump on the receptor, it's going to kick the oxycodone off, and it could put you into something called precipitated withdrawal, which is like a really severe form of opioid withdrawal, and you're going to feel awful. And if people get into precipitated withdrawal, normally they're going to the ER for an emergency visit because that's how bad it feels. So you kind of have to scare people when you get started on Suboxone. So I normally tell them that they're going to lose control of their bowels, which happens, and sometimes that's dramatic enough that it'll get people to listen to me, but sometimes people don't listen. There used to be a protocol that people would follow more where they do an in-office induction, where the patient would actually have to sit there for like 6 hours. That's kind of fallen out of favor. Some people still do that. I don't do that because it just logistically doesn't work very well. But as long as you wait and you're kind of uncomfortable, and then sometimes you can mitigate the risk by doing like a half dose to start, see how you feel, and then take the rest of the dose. That's a strategy you can do. But sometimes people on the street by accident will be taking one thing and then they'll jump to Suboxone and then they'll put themselves into withdrawal because they don't know.
How often do they take